Now I request Professor Amber Malik for updates on peripheral arterial disease intervention.
Thank you very much, Dr. Kashif. And Dr. Badr, there was a nice thought that the field must be dead if we are teaching 50-year-old, a 5-year-old information. However, let me tell you that those tips and tricks we learned 30 years ago. Right? So, okay, इसको कैसे करें? इससे change होगा? So my job is to give you some updates in peripheral interventions, which is a very, very hefty topic. So let me just talk it through. When 10 minutes are up, let me know. I may go through my time. So peripheral vascular disease involves all of the vessels, including the veins. And the spectrum of PAD encompasses asymptomatic claudications, critical limb ischemia, limb loss, and death. We will be dealing with severe claudication, critical limb ischemia, limb loss, and death is what we're talking about as interventionists. We know that admissions for CLI have increased and they have complex comorbidities. We see a lot of diabetes. We see more than 1/3 with CKD, and they are older patients. But the treatment goals are to reduce the extremely high morbidity mortality and to prevent amputation, improve claudication symptoms, and improve quality of life. And serious problems to deal with are death, gangrene, limb salvage, pain, and non-healing ulcers. And these slides are stolen from my great friend Imad Sadiq, who taught us how to do peripheral intervention. And we need a PA team, which he used to call an orchestra of interventionists, vascular surgeons, orthopedic surgeons, diabetologists, physicians, radiologists, nephrologists, and not to forget the podiatrists. This is what you need if you want to get the foot going, the limb going. I'd like you to focus on these two classifications and always present in this manner. Look at the Rutherford classification, which is a nice clinical one, and you will notice that you can have the grade 3, 4, 5, and 6 are the categories that we will be dealing with. Also remember the Wi-Fi classification. Go and look it up because it will give you the risk of amputation. It will help you know that even if you revascularize, people will still get amputated, and this is what you need to tell them before you revascularize them. And this is what this Wi-Fi classification will help you assess the risk of amputation, particularly, and this is the chart that will help you with interpretation. Then you need to understand task 2 classifications as well, which is anatomical, and we will be dealing with C and D for endovascular procedures mostly. The rest everyone else will do, because for us, only the very difficult cases are referred to us. 2017 ESC guidelines gave us endovascular first strategy for short occlusive lesions for aortoilex. For FEMPOPs, it gave us, again, endovascular first strategy for less than 25 centimeter lesions, and more than 25 centimeter lesions, it suggested vein bypass grafts. For infrapopliteal occlusive lesions, again, interestingly, it gives you bypass first, but nobody does bypass infrapopliteal in our country. So we end up doing endovascular therapy, which is class 2A. So FEMPOP endovascular intervention is what I'll focus on, and the FEMPOP segment is the most commonly treated infrainguinal culprit in patients presenting with symptomatic peripheral arterial disease. Revascularization is indicated for lifetime limiting claudication and in CLTI, chronic limb-threatening ischemia. And the decision regarding surgical or endovascular revascularization is based on anatomic and patient characteristics, and technological advances have really helped us. If you look at this chart, this is the sum total of what I'm going to tell you today, which is how much vascular access has improved and how many different kinds of vascular access there are, how many devices there are, and there are many future directions which will give us our updates. So what about vascular access? For us in Pakistan, what did we learn 15 years ago, not 5 years ago, right? For PAD were some basic tools and skill sets. In these 15 years, we have seen increasing awareness in our patient population and in our professional colleagues on how to deal with these very sick patients. Most importantly, who to refer to, rather than do life-shattering amputations. We learned the crossover or the destination sheath, which gave us contralateral access. We learned ipsilateral antegrade access for below-knee intervention and distal SFAs. We learned, best of all in the last few years, retrograde pedal access. And we learned the use of ultrasound guidance, which we will talk about more eventually in the next couple of days. And then we learned support catheters, glide cats, microcatheters like the Rubicon and CXI, and they really helped us gain access. And this is what the crossover sheath gave to us. These are guide catheters basically, and we never knew the use of them 15 years ago. But now we have access, and this is what they look like. And for the contralateral side. And then support catheters, which are available but with difficulty. Cook gives us guys. Then we learned simple wires like 3-5 stiff shaft glide wires, specialty wires. It's like a supermarket. Coronary CTO 014 long length wires, balloons, and drug-eluting balloons, drug-eluting stents, covered stents, saved lives. And with these simple tools, we learned many different things. We had access site issues, and therefore we switched to pedal, and as well as learning radial or brachial access. There were multiple, with new technologies and whatever is happening in the West, we have cost issues. So ours is a very basic armamentarium, but there is much that is happening. Plain balloons, drug-coated balloons, BMS, drug-eluting stents, limus-based, paclitaxel-based, covered stents, atherectomy devices, specialty balloons, intravascular lithotripsy, intravascular ultrasound. POBA had a highly successful, high technical success rate, 98 to 100%. However, the problem was that you ended up with provisional stenting, and there was a high risk of recoil as well as poor rates of long-term patency. And it essentially meant that 3-year patency rates were 61% for stenotic and 48% for total occlusions in the setting of intermittent claudication. And more than 100 millimeter lengths did not have very good patency rates. So you ended up putting in bare metal stents, which were self-expanding nitinol stents, which has a thermal shape memory. It gave improved patency when treating lesions more than 100 millimeter, but it still had high rates of restenosis. Then there came the era, and why do you have this problem in the FemPop segment? Because of various stresses like torsional, elongation and compression, flexion and extension. And so there came the era of drug-coated balloons as well as drug-coated stents. Drug-coated balloons have very good results as compared to plain balloons, but there is some controversy about paclitaxel-coated devices with increased morbidity, mortality. Theoretical concerns about paclitaxel distal embolization, but that conversation has been put to rest. New generation BMS were put in that had better biomechanical stresses, and so purpose-built stents were made with reticular designs as well as with helical center lines. Then they came paclitaxel-based drug-eluting stents, Zilver and Luvia. There is still some controversy about these coated devices and some concern about aneurysmal degeneration. Then there came limus-based devices, but they have less vascular toxicity, but they still have a high rate of restenosis, and that might be overcome by newer generation stents. And then covered stents can treat long lesions. Again, they have an increased risk of stent thrombosis. Then you have atherectomy devices, which reduce inflation pressures with angioplasty, just like the coronary bed, but there's not that much randomized rate. And there's so many different kinds of atherectomy devices: orbital atherectomy, rotational atherectomy, directional atherectomy, laser atherectomy. And you're familiar with orbital, rotational, as well as perhaps directional. But the laser atherectomies are a bit rare, and we have had experience with the Dabra device, which actually does not even use a wire, and can go through for instant restenosis as well as for thrombi, particularly for atherothrombotic lesions. And then you have these interesting specialty balloons, and you have intravascular lithotripsy. So it's the scoring balloons, the cutting balloons, and then this very, very interesting chocolate balloon. And they reduce inflation pressures with controlled angioplasty and limits dissection. Again, there is limited prospective data. And this is what the chocolate balloon looks like. It is covered with nitinol caged balloon with controlled dilatation, and it causes the balloon to form a series of segmental pillows and grooves along the entire lesion. The pillows apply force to create small dissections that are necessary for effective dilatation. These have really shown very good results, and so you may not need a stent or even drug-coated balloons, and just a chocolate balloon will suffice. And similarly, you have intravascular lithotripsy, and as you know, they give controlled fractures, and there is very little risk of perforation here. Then there's, of course, imaging, but again, limited evidence to support its use. And what are future directions? Novel anti-proliferative compounds have now come in, like lipophilic nanocarriers and amphiphilic sirolimus-based formulations. There is additional talk of delivery of dexamethasone, which may have future clinical utility in preventing vessel inflammation and the development of new intimal hyperplasia. And then bioresorbable scaffolds, just like in the coronaries, which will restore normal FEMPOP vasomation and decreasing in-stent restenosis. Again, and then methods for entire percutaneous bypass. And the detour system has been developed, which involves utilization of the ipsilateral femoral vein to place covered stent grafts as a conduit, bypassing the SFA lesion. It has been FDA approved in an ongoing detour 2 trial. In conclusion, the current state of FEMPOP revascularization allows for an endovascular approach to address most PAD lesions, regardless of clinical syndrome, reserving surgery for special cases or refractory lesions. It has improved patency rates, rapid recovery times, and as compared to surgery, allows for OPD procedures. I would suggest that if the fellows are here, which I see very few of, that there is a very nice reading. So this is an article from the Journal of the Society of Journal of Sky, and if you read that, you will find a lot of information on updates on peripheral arterial disease. Thank you very much.
Thank you, Professor Amber, for an excellent talk and finishing very well in time.